Okay, good afternoon. Welcome everybody for attending this webinar on the opportunity of the International Celiac Days concerning a cure for celiac disease. Where are we? To discuss that very important and exciting topic, we count with the presence of Professor Riccardo Troncone, which most of people, I think, you are an authority in celiac disease research, and we are very delighted to have you to walk us through this, what is the state of the art in research seeking for a cure to celiac disease. He is a professor and head of the Department of Pediatrics at the University Federico II di Napoli in Italy. His specialty is pediatric, but he also been trained in mucosal immunology. And as I said, celiac disease represents, I think, his main interest. And for what I know, most research and doctors working with celiac disease are really passionate people, and Professor Troncone is not an exception on that. He contributes to multiple research areas in relation with celiac disease. He's also at the university, participates in the Center of Excellence established by the Italian government, the European Laboratory of Investigation of Food-Induced Diseases. And he's also a scientific advisor of AOACS member, the Italian Association of Celiacs. What can I say? So we will have 30 minutes presentation in total. I will give him the floor immediately to show us, to portray the situation. And then we will open the floor for questions and answers with you, hoping that we will have an interactive debate. But before doing that, please allow me a few words about celiac disease, although of course Professor Troncone might elaborate further, and also about who we are, AOACS. So celiac disease is an autoimmune disease caused by the ingestion of food containing gluten, which is a type of protein that can be found through different cereals like wheat, barley, and rye. Celiac disease may affect about 1 to 2% of the population, and if it remains undiagnosed, it can result in symptoms ranging from minor discomfort to life-threatening conditions like severe anemia. Today, the only known effective treatment is a strict lifelong gluten-free diet. The Association of European Celiac Societies, AOACS, which I honor to represent, is a non-for-profit umbrella organization made of national celiac societies in Europe and beyond. Together with our members, we represent the voice of celiac patients and their relatives in over 40 countries in Europe. We promote strategic partnership to raise awareness on celiac disease, encourage research for improving the life of celiac, early diagnosis, and of course, the cure. And we encourage also giving better access to safe gluten-free food. So AOACS owns the AOACS standard for prepacked food products and the cross-grain licensing system, which is managed by our members, the national celiac societies in the respective countries. Thanks to that, we allow thousands of safe gluten-free food products being available in the market and easily recognized by any consumer. As a housekeeping rules for today, please notice that by participating in this webinar, you agree that the webinar will be recorded and eventually posted as a public domain in our YouTube channel. And please do not hesitate to keep yourself mute and share your questions in the chat so that we can address them after the presentation. And without further delay, I give the floor to Professor Troncone. Thank you very much for taking the time to be here with us today. The floor is yours.
Thank you. Thank you very much. I hope you can hear me well. And thank you for your presentation. And thanks also for having introduced the topic of today. As you said, celiac disease, sorry, I'm trying, okay. As you said, celiac disease is now, I mean, the same concept of celiac disease has changed over the years from an enteropathy, a disease of the small intestine, to a systemic disease, to something which affects the whole body. And the mechanism seems to be an immune mechanisms, particularly autoimmune, in the sense that there is a response against some proteins which are of our own body. The interesting thing is that because of those characteristics, celiac disease has become a model for so-called organ-specific autoimmunity. Also diseases which are quite different from celiac disease, like type 1 diabetes or multiple sclerosis, are very different from celiac disease, but they have this common trait of being an autoimmune disease. For celiac disease, the solution is not complicated because this is an autoimmune disease where the triggering factor has been identified as gluten. So removing gluten from the diet is the very effective treatment for the disease. Having said that, why we look for a drug for the therapy of celiac disease? There are several reasons for that. First of all, gluten is really diffused worldwide. I mean, and it's a very large diffusion, presence in our life, in our environment. So there are difficulties in avoiding inadvertent gluten exposure. The gluten-free diet is a diet which is, although is balanced, is not, exposes to the risk of some nutritional deficiencies like fiber and whole grain intake. Third, because of the importance that gluten has in our life, in our diet in general, in our social life, that means that there are problems in compliance with the gluten-free diet. And that can lead, in some cases, also to a quality of life which is compromised. And finally, a last but not less important cause is that there are also some patients who do not respond properly to the gluten-free diet, whose symptoms remain despite the gluten-free diet for several reasons. And we have also within this a very small, fortunately, a very small subset of patients who have quite a important disease, which is not cured by the gluten-free diet, which is called refractory celiac disease. This is a condition that, as I said, concerns only small groups of adults, is not being described in children, fortunately, and in some cases can be very, very severe. Okay, so these are the reasons why we look for something that can cure celiac disease. Now, this slide is very complex and it's very difficult for me to go through, but it's important. It's important because these are the different steps of how gluten can be harmful to celiac patients. There are several steps where that can happen, and each of those steps can be the target of a specific therapy, again with the aim to restore the ability to eat without problems gluten. So it's very difficult. Let's say if you see my pointer. So this is the intestinal lumen where there is gluten, okay? This is the epithelium, the barrier. And this is something which happens below this barrier. And we will now discuss which are these different strategies. Let's try. So the first one is going from the lumen inside. In the lumen, there is one important problem, that gluten is digested very with great difficulty by all people, not only celiacs. Gluten is something which is digested with is not easy to digest because it's a structure. Because we as humans, we lack some enzyme which are critical to digest completely gluten. So this is a very first point. The second point, that the barrier is very important, although we know not very much about that, but we have to, we can influence the response to gluten, trying to influence the ability that gluten has to cross this barrier. And here, in the lamina propria of the intestine, is where the immunological events take place, where gluten is recognized as a substance against which the body mounts an inflammatory response. And that happens only in celiacs. Because in other people, like any other food antigen, that is tolerated, let's say. But in celiac, for reasons which are not completely known, this protein, the gluten, is seen as something against which to mount a defense, an inflammatory response. So we will go now to look at the different strategies from the lumen to the barrier inside. And so the target of possible therapeutic interventions include tend to correct, let's say, the impaired gluten digestion, tend to influence intestinal permeability, and then in the lamina propria tend to influence the immune response. Again, I repeat to be clear that normal people is tolerant to gliadin as to any other food antigen. But in celiac disease, gluten is seen like, something to fight, like a virus. So there are two main strategies. Having said that, one is trying to reduce the gluten or to avoid that the gluten comes in touch with the immune system in the gut. And the second group of strategies influence the immune response. So let's go on the first part. So how to avoid that the gluten comes in touch with immune cells. First of all, we know now in gluten which are the part of it who elicit an immune response, which are toxic, let's say. We know we have identified them. And one possibility is to try to genetically modify the wheat to avoid, to eliminate those parts which are toxic. So there have been realized varieties of gluten with low immunogenicity, which are, as I said, devoid of the toxic part and then unable to activate T cells. However, this strategy is not still working because the ability to activate T cells, so immunogenicity, is reduced, but not at a level completely safe for celiac patients. And second, there are also social and political problems because there is no acceptance in general of using genetically modified organisms. However, this is a strategy that in the long run could still give results, but at the moment is not pursued because of this concern by the, for instance, in Europe more than in other countries, that to use genetically modified organisms. Other strategies to reduce the amount of gluten which could come in touch with the T cells, the cells of the immune system, are sequestering gluten into the lumen of the gut. Those are a number of substances, resins, who tend to keep gluten and not to allow him to cross the epithelial barrier. Second strategy, to use enzymes. As I said, humans have enzymes which are unable to digest gluten. So if we can give enzymes from other sources, let's say bacteria or yeast or other things, those enzymes can digest gluten and makes it tolerated by patients. So this slide, a bit complex, is just to say you that gluten has this characteristic of being not well digested. And you see that there are some very large pieces of the molecule who are not digested and as such can cross the barrier and activate T cells. So the use of the enzyme, and we have several type of enzymes which have been produced. This is from fungus, for instance. This comes from bacteria. This has been engineered. So all of those are preparation of enzymes able to digest gluten. And if they are given together with gluten, they avoid that gluten activated T cells and is toxic. There are 2 randomized trials in 41 and 43 patients which have been given 2 grams per day of gluten. And in those patients, the administration of the enzyme was able to prevent mucosal damage and symptoms. Okay, so this is an important approach, probably the most close to use. I must incidentally say that at the moment, there are no drugs. If you go to the pharmacy, you cannot find any drug to cure celiac disease. So all of those are still at the experimental level. And so, but the use of enzymes is very promising. The third approach to avoid that the gluten comes in touch with the T cells is to work at the level of the epithelial, of the mucosal barrier. Here has been used a molecule called lazarotide, which is a molecule which is, by a mechanism, is able to reinforce the mucosal barrier. However, and that has been tested in many trials. The last one with quite a large number of patients showed no effect in terms of protection from mucosal damage. And so because of these disappointing results, this trial was suspended a year ago or almost 2 years ago. And so, and since then, as far have not been published other papers on this approach, which I repeat is based on the use of this molecule and on the reinforcement of the epithelial barrier. Let's go now to the other strategy. The gluten past the mucosa, but now we are working here, trying to have a non-reaction by T cells to gluten. The non-reaction by T cells to gluten is let's say, this is again quite a complex, but I have to wait to explain. This is the we understood from many studies conducted on T cells. T cells are the cells of our immune system. I repeat, T cells, normal people has not T cell against gluten, but celiacs they have. And the reason for that is not completely clear. T cells to react to gluten need that gluten is presented to them by this molecule, these cells, which are antigen-presenting cells. These cells have on their surface a molecule which is coded by HLA genes. And this is the reason why HLA is so important for celiac disease. We keep studying and saying that HLA is important. If you have not such a HLA, you cannot be celiacs. And the reason is that this HLA creates molecules that are able to present gliadin to T cells. If you have not such a molecule, you cannot be a celiac. But there are other ways to influence this process of presentation. This presentation needs, for instance, that some of the gluten is transformed by the use of an enzyme which is called tissue transglutaminase. And so if you block the transformation of gliadin by this enzyme, it will be unable to activate the T cells. And so inhibitors of these enzymes, inhibitors of this ability to change the structure of gliadin have been tested in clinical trials, and this one is very promising, and it abrogates mucosal injury and improves symptoms and quality of life. So this is another way. I'm sorry, this is very technical and not easy to explain, but the other way is to try to, and this is what we called once vaccine. It's not a real vaccine, but it's a strategy by which the T cells, which are directed to gliadin, are rendered, let's say, anergic, unable to react. And that has been obtained just giving, some of the peptides in a certain way, some gliadin, in order that you do not get an inflammatory response, but what we call a tolerant response. So it is tolerated. And there are several ways of, doing that, modifying gliadin and including gliadin in some particles. So the final result is that the immune systems does not see any more gliadin as something offendant, but something that they can tolerate. There are many studies going on this. Some of them, unfortunately, have been unsuccessful, but the research is going on with the use of those nanoparticles, so little particles where gliadin is included and is able to elicit from the immune system a tolerogenic response. And finally, there are other, again, strategies which work on the molecules which are produced by the T cells, the so-called cytokines. Those are antibodies who make those cytokines unable to exert their effect. And there are some cytokines which are very important in celiac disease and which are responsible of the mucosal damage. For instance, gamma interferon, interleukin-21, interleukin-15. Those are very important molecules produced by immune cells. They are responsible for the mucosal damage. And probably one of the most important is IL-15. So an antibody against IL-15 protects celiac patients by exposed to gluten challenge. But more importantly, IL-15 is has a big responsibility in the pathogenesis of refractory celiac disease. That condition that I said to you before is a disease with a very nasty, with a very poor prognosis. Unfortunately, quite rare, but is still there. And I-15 can cure this condition. So the last part of my presentation is just to going more in general. So I tried in the first part to give you the different steps of the disease and where the drugs may interfere. But once we have a new molecule, we have several models in vitro and in vivo where to test. There are cell lines, organoids, which are in vitro, resemble the structure of the gut, T cells, organ culture. Unfortunately, we have not an animal model for celiac disease. This is a big problem because for other diseases, we have animal models, often in mice. But in celiac disease, we have something which seems or goes close to celiac disease, but not in animal which is celiac on which to test, for instance, some of those drugs. And most of the studies which have been conducted so far have been conducted mostly in adult patients, only in adult patients. There are not studies and no tests of these new drugs in children. But also in children, there is an unmet need of new therapies. Also in children, we have, although less than in adults, some of the problems which requires these new drugs, like no response to the gluten-free diet or inadvertent exposure to gluten. Furthermore, in children, there are some of those scenarios which are not much present in adults. Let's go through these slides for a moment, which is important because it's the slides that describes in which situations we want to, for which aims we want to use these new drugs. First, prevention. This is something which is peculiar of children. We know now that it's possible to prevent, or we try to prevent celiac disease in those infants, in those children who have a very high risk of developing celiac disease. So prior that the disease is developed, try to stop and to avoid that the disease will come out. We have then another condition, which is still prevention, but at a different stage. There are children, for instance, also adults, but there are children who have autoantibody, anti-tissue transglutaminase antibodies, but have not the mucosal damage. And we would like to have molecules, drugs, who prevent the evolution of this from this stage to the full-blown, the complete, the overt, the active disease. So this is another situation where a third situation is when the patient, and this is the most investigated so far, the most important group of patients which has been candidate to these new therapies. So are patients which are diagnosed with celiac disease, are put on a gluten-free diet, but despite that, the mucosa does not heal. And we need something in addition to the gluten-free diet to guarantee that people mucosa heal completely. Then we have another situation where the patient are diagnosed with celiac disease, are put on a gluten-free diet, they heal completely, the mucosa is okay on a gluten-free diet, but the patients want to make sure that they do not incur in any risk of going to the restaurant, for instance, or they deliberately want to assume a small amount of gluten and want to be protected from them. And this is another group of subjects which are candidates to the use of these new drugs. And the ambition, but this is very difficult at the moment, is to find a therapy which is completely alternative to the gluten-free diet, which allows people to be considered completely cured. I think that we are a bit far from this at the moment. But each of these situations has its own kind of test and how we can measure the ability of drugs to work. There are, which are the outcomes which are investigated. The most important is histology. So histology needs to be looked. If you are on a gluten-free diet and a mucosa which is not completely healed, you have to demonstrate if the drug is efficient, the drug should cause mucosal healing. If you have a patient who has a completely normal mucosa but wants to eat small amounts of gluten or want to be protected, but from a small amount of gluten, again, you have to submit the patient to a gluten challenge and show that the drug is able to produce no change by gluten on histology. There is discussion if there are other outcomes apart from histology, which obviously is clearly a bit invasive because means that you have to make a biopsy before, a biopsy after to demonstrate that the drug is efficient. So there are other two outcomes, symptoms, to demonstrate that the drug is able to protect from symptoms, or serology, that the drug is able to avoid the appearance of anti-tissue transglutaminase antibodies. But those outcomes are less important than histology, cannot replace, in our view, histology, because symptoms have not a clear relation with the state of the mucosa in celiac disease. You can have completely destroyed mucosa and no symptoms, or you can have a small damage and many symptoms. So symptoms are not a reliable outcome to judge if a drug is good or not. Okay? And finally, particularly for children who have not so far undergo any of those trials, there are particular problems that we are going to study and to face in the future. The dose which will probably, because the infant is not a little adult, it's different. So you can probably have different doses, a different pharmacokinetics, how the drug is disposed. There are drug-specific risks that need to be taken into account. As I said, to test the efficacy of the drug, you may need invasive interventions like, endoscopy. And in children, which is an organism in growth, obviously gluten challenge may be disturbing that, may cause problems. So there are all problems. And finally, you need, particularly in children, that the approach you are using has a long duration effect. So this effect of inducing tolerance should last the whole your life. So in conclusion, I'm not going towards the end, I hope that I know that it's not easy, this topic, but I try to explain you where we are. As I said, we are not already in the pharmacy. In the apothecary, we have not drugs on the shelf, but we have many trials going on. I try to explain you or to discuss with you, to present you the different scenarios, because we talk about drug for celiac disease, but we have also to understand and to think better for which aim. Do we want to counteract symptoms despite the gluten-free diet, or do we want to make the patient able to tolerate small amounts, or so on? So different scenarios, which means different protocols, different drugs, maybe different outcomes. But of the many approaches that I mentioned today, I would say that maybe the most close to real use are probably the enzymes able to completely digest gluten. But there are also others which are more ambitious, but even more promising. And soon, I'm sure we will see also trials involving children, although, I mean, a number of questions, particularly related to safety and ethical problems, need to be solved before. And I thank you for your attention.
Well, thank you so much. Bravo, Professor Troncone, for making easy this complex topic. I see already a lot of questions on the chat that I will address to you. But first, most important, I heard, rumors has it that you have received a prize from the Coeliac Foundation, and we really want, on behalf of all the AOACS members, to congratulate you, because it's certainly a very deserved prize. Thank you, Professor.
Thank you very much. Thank you.
There is a question from Ronald Hopper asking, can the T cells of patients potentially be used for diagnosing celiac disease?
Yes, this is really something, a frontier of, because I say, first say that we have very good diagnostic tools for celiac disease. Tissue transglutaminase antibodies are very powerful. There are not many diseases that benefit from having such a simple test to make a diagnosis or to help in diagnosing and in finding celiac disease, also where you have a very little suspicion. But having said that, T cells, as we saw maybe from this presentation of today, are crucial in the pathogenesis of the disease. And T cells to gluten are only in celiacs. So finding a T cells to gluten may also have a diagnostic value. And there are people who is working on that, either counting T cells to gluten or measuring the production of cytokines, these molecules, following gluten challenge. So certainly this is a way which will give a lot of results in the future. I've just been at the DDW, the American Meeting of Gastroenterology, and there have been more than one presentation just focused on this use of T cells, of cytokines produced by T cells to make a diagnosis of celiac disease.
Brilliant. Thank you so much, Professor. There is another question from Roberto Gomez asking if there is it lack of funding or lack of awareness an issue for finding a cure to celiac disease, or is something else, or both?
No, I think that now I think I'm not able to make a comparison with other diseases. I suspect that certainly there are more funds invested in type 1 diabetes or in multiple sclerosis to find a cure. So but certainly, I mean, for celiac disease, there is a gluten-free diet represents a very important competitor in terms of cost, in terms of safety. So any drug which is used for celiac disease must have a safety profile which is which could compete with the gluten-free diet. This is something that we have to take into account.
Interesting. There is a question from Susanna Nuhold. Which children's or infant could be considered for primary prevention? You mentioned it at the beginning.
Yes, yes. I think we are talking about infants born in celiac families where there is already one case. We know that those have risk in general is average. If they have the right HLA, they have a risk about 15–20%, but can go until more than 30%. So 1 out of 3 if they have a certain HLA, and also if they are females, because females have a higher risk. So we know that there are infants already at birth in such families that can have a high probability of becoming celiacs, and maybe they could be the target of such prevention.
Okay. Thank you. There are 2 questions on the chat from a person. The first question is that this person have heard there is an experimental therapy to deprogram cells, and maybe T cells, that cause an autoimmune response. It has been used successfully in lupus patients and other autoimmune disease. Is that something being considered for celiac disease?
I don't think, if I understood the model, I don't think that there is any trial at the moment using this approach.
Mm.
But what I want to emphasize here is that the research on celiac disease is also important because, as I said at the very beginning, celiac disease is now considered a model for autoimmunity, maybe more organ-specific autoimmunity, like type 1 diabetes, multiple sclerosis, more than lupus. But those research are important also because they may give some hints and to other diseases, and we can also import the experience in other diseases, like, for instance, the type 1 diabetes. We know now that there is a drug which is able to stop the evolution of type 1 diabetes from pre-diabetes to full-blown diabetes. And maybe that same drug can be used in the future also for celiac disease.
Excellent. The other question will be, when therapies will be available in the future, they could be customizable type, very expensive, maybe more effective, or available as a generic drugs, as you have said. What do you think is a better path to pursue? I'm worried about cost of this treatment once it is available.
I understand, but I have no idea at the moment how much how will be easy to introduce. Maybe we can look, as I said, from the experience from other diseases.
Mm.
And I think that also depends on the different health systems and how they are ready to pay these expenses.
Wonderful. Yeah. It's early to say, right?
It's quite early, yes.
Early to say. There is another question from Sophia Growers saying, well, she has 2 children with celiac disease, 10 and 6 years old. Although different to predict and considering medical development take time, when will be your best guess that there is a medical treatment for celiac disease allowing celiacs to eat gluten? That's the
Again, very difficult. But I heard some also other experts saying that maybe within the next decade we can have them.
Next decade. So maybe I there introduce my own question, because I was thinking you mentioned that the enzyme treatment is like the most promising one, and if that will be the case, the earliest to appear in the market, will that be in combination with gluten-free diet or instead of?
Oh, I mean, can be used in both cases, but because we can use this in two different, as I said, possible scenarios. One is to complement gluten-free diet when this is not able to control symptoms. And the second one is if we want to just have slight light transgressions, or or make you sure that when you go out, you are protected to some extent by the inadvertent ingestion of gluten. So usually those tend to complement the gluten-free diet to make the gluten-free diet more efficient or more easy to have. I mean.
Yeah, to have less risks. I see that we have we have gone beyond the time for a few minutes. Maybe the last question, but it's quite complex, are the person, Maria Isea, says, are all the options stopping the autoimmune response? You already explained a little bit about that. That is also for the primary prevention are also very far.
No, I mean, if they're able to, I mean, the approach working on I mean, the enzyme, they do not stop the immune reaction. They just avoid that gluten, comes in, so is able to activate the T cells. But the most, as I said, more ambitious are the attempt to restore tolerance, and we have also to then to understand how far that can go, how long can last this induction of tolerance, and if the autoimmune response is really blocked forever.
Brilliant. All right. I think we really managed the time very well. Your presentation, Professor Troncone, has been amazing. I think we all have nourished from this experience. The fact that you say that the landscape is a decade ahead is very promising. Of course, we will have the opportunity to follow up on the development with you, and well, thank you so much for taking the time to be with us.
Thank you. Thank you to all of you.